So I think we're going to go ahead and get started just because ours will probably take the full 50 minutes. So I'm Rose Fernandez, and this is Elizabeth Rosenman. I'm at the University of Florida, and Liza is at the University of Washington. And what we're going to really present to you today is a translational research model and an example of said model in practice for linking simulation-based training to actual patient outcomes. And let me make sure that this, oh, that did work. Okay, good. So our work is funded by HRQ, so I have to get that in, as well as the fact that we have no conflicts. We usually do acknowledgements at the end, but we really wanted to make sure we had time to put this slide up. This work takes a lot of effort, and this is just a list of kind of our key personnel. As you'll see as we go through this, there are work study students and data processors and video processors and sim techs that are not reflected here. So we at least wanted to make sure that these names got up on the board. Our objectives, as you all noticed from what you responded to and came to, are to really make sure that at the end of the day you can describe some of the issues related to recording clinical events, some of the issues related to study design itself when you want to measure clinical performance, and some of the challenges associated with linking human performance with patient outcomes. And so what we're going to do is give you this through a framework of translational research for simulation. So we're going to present a conceptual model. We're going to go through that kind of quickly so that we can get to the actual research program that we put together and allow a lot of question and answer so that we can address any questions or concerns that you might have. We're going to focus on some of the challenges that we had related to implementing our training, and then the data collection that was required, and some of the measurement challenges that we had when we translated from a simulation center to actual clinical environment. So first, translational research and simulation. So I think everyone's familiar with some form of the NIH translational model. I think most of you have seen some of it. Sometimes there are 5 circles, sometimes 4 circles. This one happens to have 3 circles. But essentially the idea is, how do you go from bench to bedside to population? How do you do that? And when you look at the NIH model, it's basic science. So it's a rat to a human to a bunch of humans. And that's what they're thinking about. But the important part is that where those translational arrows exist, right? So it's the idea of, how do you translate that? How do you take knowledge that you've developed in a rat model and move it to a human? And so when people started to do this for medical education research, Bill McGahey was one of the first folks to do this and publish this, I believe, both for simulation and for medical education. But he started with a T1 level and said, hey, this is the equivalent of a bench, and it's a multiple choice question, or it's a simulated environment, or it's a standardized patient assessment. There are a gazillion ways to think about this, but that's your basic science level for medical education. And then he said, okay, then you go to this T2 place, and that's how people actually practice in the clinical environment. That's what you're trying to understand. And then there's the magical leap that one makes to T3. And this all made sense, and this looked good, but there's a big difference between what's listed here and what was listed in that NIH pathway that you saw. And the difference is that this labels the actual level as translational, right? So in this case, if you go back, let me see if I can go back without destroying this. So here the translational, the T1, is actually going from bench to bedside. Here, bench is T1. And so what gets lost, it's subtle but I think important, is the fact that what we have to do is translate the work, is figure out how to get from one place to the next. And so we thought that was important enough to kind of draw a different picture. And this isn't rocket science, and this isn't going to change the world, but it's the idea that we're not calling that first box T1. That's basic science. The translation happens when you take the knowledge that you've now gleaned from the T1 level, or from, see, I do it myself, from the basic science level to that patient-centered outcome level. And so we are, most of you are here because we said we're doing simulation, but this fits for really medical education in general. But as you all know, when you're in a simulator, you can control when it happens, what happens, who's involved, right? You can control the team. You can control the metrics that you're going to use to match to the event, all of that is very controllable. Even your data collection, right? You know the mannequin's going to be here, so you're going to put the camera there. Very different, as you guys all know, when you go to do this in a clinical environment. Now you've lost a lot of standardization. The patients differ, right? So we're not talking about in situ SIM. We're talking about true clinical events. So the patients have variability that is associated that you can't control. There's the team, the environment, the flow. All of those things are now variables that you have to consider that we didn't have to consider when they're in the SIM environment. And then there's the whole data capture piece, right? We can't just like walk around with cameras and follow people and understand what they did. And so that's the T1 challenge. The T2 challenge then takes that variability up a notch and says, okay, now we want to look at patient outcomes. Well, oh my gosh, what does that look like? Because now we have the fact that multiple different teams have taken care of the patient. We've had an ED encounter, and we want to understand mortality. At the end of all that, what is that going to look like? And so those kinds of T2 translations become really difficult because we haven't really gotten good at defining what the right outcome is, how we're going to measure it, how we account for the variability, and it's expensive. It's really expensive when you think about some of these clinical trials that cost $14 million. That's what you're talking about, and that becomes a big challenge. Now, there have been successes, and you all probably are familiar with them, and probably one of the biggest ones was central line training, right? So people figured out you train central line training along with a very clear protocol, so it wasn't just the training, we can decrease line-related infections. And so one of the factors that made this so possible was the fact that CVC's placement of a CVC is a complicated but not a complex problem. And some of you may have heard that, or that may sound like kind of like semantics, but when you think about a complicated problem versus complex, which we'll talk about in a minute, it's a problem that you can reduce to its parts. So while placing a CVC may be really hard, you could write down what all the parts are, and the whole is the sum of the parts. If I say to you something about communication, can you write those parts out, and the whole is not the sum of the parts? And so that's the difference between something that's complex versus something that's complicated. And complicated problems can be addressed with new protocols and algorithms. Complex problems cannot. And so that was one of the reasons I think the CVC project was so successful. Part of it was that because of the way the hospital did their work, the data collection was built in. They already tagged lines so that they could follow the exact line that was placed by the person who placed it, which gets rid of some of the challenges that we have. So they could define the participant, and then the outcome was pretty closely linked. I mean, it's not 100% by any stretch, but the idea that you place a line and you get a line infection versus I communicated well and so the patient lived longer. Like, that's a little bit of a stretch. And so what makes other problems hard, like we do team science work, are that the problems are complex. There are a lot of confounding variables. The data collection can be really hard, and the outcomes are really hard to define. So what we're going to move to now is just an overview of what we did, and hopefully that'll spark some questions and maybe some answers for you. And we'd like to make it as interactive as possible, but we also are trying to make sure we get through everything and have time at the end. So we'll try and balance those things as we go through. So what we were trying to do was use simulation. Overall, our program is to understand human performance. We're interested in understanding healthcare human performance, both individuals and teams. And what characteristics of the individual, the team, the system support effective performance. So these are complex problems. These are not complicated problems. And that alone is a challenge. So we tried to then build this model to make sense for our work. And we have performance in a laboratory setting. Okay? The team science literature would tell you that you don't just measure how the patient was cared for, but you measure what the team members did. That's the process piece. So you measure both process and performance. you would do that in both a lab setting, so simulated setting, and then you'd want to translate that into an actual clinical setting. And then we can start to think about what those patient or provider or family-centered outcomes should look like. And that's where our work is sort of centered. We have not even thought about T3, like can't even go there. But most of our work is spent looking at T1 and then a little bit of T2 effort. And so, Liza, do you want to just use this? Just snap on.
Sure.
Liza's going to take over for me for just a moment.
All right. So we knew that we wanted to train team leadership. We knew we wanted to do a control trial. And we knew we wanted to use simulation. And we knew we wanted to use video-based observations of the emergency department. So we knew that that video component of it would present some challenges for us because it wasn't already established in our institution to record clinical events and judge them later. But we had a lot of additional, less highly anticipated hurdles along the way. And so we just want to talk through some of those. Obviously, there's not going to be a one-size-fits-all if someone wanted to try something similar in their institution. But what we encountered, some of the compromises or trade-offs we had to make, and some of the things that worked really well. Spoiler alert here, we don't have results for you today. So if you're here for those, I'm sorry. We're at the data analysis stage, so stay tuned for those maybe next year. So specific challenges, I'm going to start with training implementation. I will say now, in retrospect, this was the least challenging component, and that's because we're done with it, and it went well. But at the time, it was actually harder than we thought. We wanted to train leadership. Obviously, we wanted to train leadership, and we knew that. But as Dr. Fernandez mentioned, it's a complex construct. And it's variable in what good team leadership looks like. It depends on the patient, the environment, the team. And so we wanted something that would work in our institution, but that was also transferable. We were doing trauma resuscitations, but we wanted it to work for resuscitations in general and at other institutions. And so fitting it to be specific but general was tough. So we went back to a lit review that we had done years back to kind of gather, don't read this, but a behavioral taxonomy of leadership behaviors. So this is a lot. This is healthcare action teams, resuscitation teams from all specialties. And these are the behaviors that emerged. And so we were able to use this as a building blocks to then say, these are the key behaviors that we want to be the foundation of our training, so that we knew our training was solid and could be universal at its base. But then we had to kind of tailor it to our institution. And that's where the simulation component of it came in. So we had a 4-hour training session, 2 residents, and kind of initial hour of traditional didactics, and then we got into the simulation. And they would do a simulation, one would watch the other one. We involved them in doing a checklist to observe their peer, to be involved in the debriefing. They both did it. And then we did a second round of simulations, and that was really tailored to the skills that were identified that they needed to work on most. So either they self-identified or we observed in the first sims, like, you know, one of the key things, I'll give you an example. We wanted them to set priorities. Setting priorities is something that came up on that behavioral taxonomy. But and we all know what that means, but then teaching our learners to when and how to implement that in resuscitation. And some would do that really well, and we said, we don't need to work on that on the second sim. And some just couldn't do it. And so we'd specifically tailor that sim to make them so that there'd be more injuries, and someone would be calling in, and they'd have to figure out what their priorities were and let their team know. And this is kind of that horrible behavioral taxonomy that I showed you. But this is the kind of core things that we pulled out that we wanted to focus on. Like, for example, we didn't focus on debriefing, not because it's not important, but because it often doesn't happen at the bedside, and because it has a whole body of literature on it separate from this. And so we took those root behaviors we were interested in, put them into communication events, briefs and huddles, and tied them to events during the resuscitation to make it more concrete for our learners. And then we put them in an environment that we could make it, short of being in situ simulation, we made it as realistic as we could, and not at the patient, because that didn't matter. We wanted to recreate the stress of that trauma bay. the noise, the distractions. And so all of these people that you see here were specifically trained so that if the leader was not giving them good direction, or we wanted to challenge the leader more, we'd be in their earpieces letting them know, ramp it up. They'd start getting out their cell phones and sharing photos. They'd talk about their weekend plans. We would call in overhead. We'd call in with it as a nurse with another patient. We had background noise playing, and consistently that they came out saying, wow, that was loud. And nobody would listen, and they were chattering about stuff that didn't matter. And we're like the trauma base sometimes? And they're like, yeah. And so that leap of taking those behaviors and actually implementing them, behavioral change is hard. And this would get them one step closer. So then who to train? So this, for us, was actually started out quite simple. We have a role called the trauma doc in our institution. And it is a resident who is expected to respond to all the ED trauma resuscitations for the early part of the care. But it could be a EM resident from our institution, it could be a general surgery resident from our institution, or it could be an EM resident from an outside institution. We have a rotating group. And they could be second or third year residents. But beyond that, we're in academics, and there's a hierarchy, and there's personalities, and depending on the acuity of the patient and the level of the activation and the time of the day, you may get 3 people responding, or you may get 25 people responding. And you have a lot of people who are interested in that leadership role. And then we're in this multi-team system. So it's not just our EM team. There's anesthesia, sometimes. There's general surgery. Sometimes there could be peds or OB. So figuring that out, and just understanding, we had to accept the fact that we were training our trauma doc, but there would be times that leadership role would be taken from them. We also had to accept the fact that in our next step, when we take this to other institutions, that person that gets trained might be a different person. There's some places where mid-level providers are involved. There's some places where it's almost exclusively general surgery or exclusively emergency medicine. So when to train? And this became the most logistically challenging. Probably most people here are educators, and you have to align your learner's schedule with your schedule and simulation resources. But then on top of that, we had to get enough time for pre-assessments and post-assessments. And so we wanted this nice little month package. It was going to work well for us. We have people who rotate through, and they're only there for a month. So we knew that we had to get all of their pre- and post-assessments in a month time period. But then we have our own residents who rotate at 3 institutions, and so they might not get enough time in the emergency department to get what we need. And so our initial goal had been 15 days of pre-training, train, and 15 days after. And we weren't able to stick to that exactly, but I think we did pretty well. We got our training window was in a 3-day period. And that took a lot of our program coordinator. It was amazing, but a lot of swaps, including our faculty going in and working as EM residents for 4 hours to spring someone to come to this training. Because once you had the SIM center, you had 10 people who agreed they could come to the SIM. You have 3 people eligible that month, and then 1 can't make it because they're actually on vacation, and you're down to 2 people and you need them both, and 1's on shift. You'll do whatever you can to not miss that month of enrollment. So we got pretty creative. They swapped for us, we swapped for them. Initially there were some issues with getting interest from the residents, but once we had enough people go through it and they loved it, then they really wanted to be in our training group, and so then they'd be willing to swap shifts to do this.
Even the surgeons. Which was a huge
boom. And our outsides were the second institution. They have to drive about an hour, and they're like, we're not coming on our off days to do this. And then 2 of them did it, and they went back. And next thing you knew, our coordinator had the emails from all of them going, we want to do it, we want to do it. So it was a snowball effect. So in retrospect, I can say it wasn't a challenge, but it was. And of course, the whole reason we care about this window is the potential for decay. And yes, that potential's there. Do I know when that happens? No. It's a good question, but not the question we were asking. So we were trying to keep it as contained as we could and as proximal to the training, but made a few concessions. So now I am briefly going to hand that back over. Okay. And maybe next time I'll just use mic.
Okay. So then I might fling the mic somewhere.
Keep doing that.
Okay.
I know I gestured too much.
No, it's all good. Okay, so data collection was a big challenge, obviously. How do you collect data in a clinical setting? And so our timeline, just to show you what we did, so we started enrolling in April of 2016. our data collection began in May 2016 because we had that pre-post design, right? So you start collecting data before you have the intervention. The first intervention was delivered in June 2016. It was tested prior. So let's be clear, there was testing the SIMs and getting feedback and doing all that kind of good stuff that you're supposed to do. But that was when we first actually had enrollees go through. And then our last, people were enrolled in September of 2017. Our last intervention, yay, was in November of 2017. And our last video recordings was in January of 2018, early in the year. So that was sort of our timeline. And so video recording. That was the big part of our data collection, and that's what we're going to spend kind of a fair amount of time on. We'll talk specifically about the IRB, but also spend a lot of time on risk management issues because they are separate, but they go hand in hand. We'll then talk a little bit about how we did baseline performance in that pre-part, and overall the number of clinical encounters that we had to use. And so video recording is kind of like the elephant in the room, right? Like a lot of people do it in their center, but a lot of people are like, how did you manage to make that work? Because even though they do it, they're not necessarily allowed to keep the videos. And so our big goal was to keep our videos. We didn't want to have to erase them or delete them within a certain period of time, which is very common if you video record for QI purposes. And so I have an arrow here, but not there. Good, okay. So part of the first piece was deciding what kind of equipment we needed. And we did this after we had initially started discussion with risk management, which in retrospect was a really good sort of flow of events because they made it clear that there were some things that were just not going to fly. And so it was very clear that if we wanted this on a network, so if we wanted to record straight to a network, it had to be not the hospital's network, but still HIPAA compliant, which is incredibly expensive. And so that just went away right away. But I don't know that I would have even known that those were the rules if I hadn't talked to risk management first. So we went with secure locked hard drives with internal backup. And they had to be really pretty big because imagine the amount of video, which we'll talk about in a moment. But they had to be pretty large, and there was one for each bay. So to give you an idea of the setting, we have a 12-bed sort of trauma area. But of those, 4 are really like where the sicker patients go. And so that's the area we focused on, but we couldn't afford 4. So we had 2. So our 2 sickest areas sort of got their treatment. And we worked pretty hard with our nurses along with like some incentives which isn't the culture in our place. Once the patient goes to CT scan, if they're coming back, they go to a different bed so that we'd turn those beds over so that we could get as many encounters per subject as possible, if that makes sense. So we decided that was the equipment that we wanted in terms of the networking and the storage. Sound was a big issue, and we knew that sound was a problem from talking with other people who said our biggest challenge is sound. So we said, okay, and that's where we spent the most money. So for our recording equipment, we went to the people and we said our sound has to be as good as it can get because we knew we couldn't like individually mic people. And I think now looking at those videos, I'm pretty happy with it. The things that we can't hear are things that would sound chaotic even if we were in the room. So we're overall pretty happy with that. The next big piece was about activating the camera. So I kind of listed up there like sort of 3 options that were presented to us. So it could be motion sensitive. They could be human activated. So some places use this where like when the trauma comes in, somebody like hits a button or something and the cameras turn on, or they could run all the time. We sort of decided against the human activation piece because A, we didn't want to risk losing video because somebody forgot, because it's not a standard part of what we do. And B, we didn't want people to be aware of the cameras. So after looking at the videos, we promised people were not aware. They clearly forgot that they were being recorded, me included. So we were left with this auto-activate and run all the time. And essentially, it was pretty simple. The auto-activation cost more, but would still require a lot of the post-processing that we'll talk about. So we just decided to have them run 24/7. And that's what the cameras do. They run 24/7. But that means that there's some significant post-processing. So very briefly, what happens for this is we're able to look at the trauma logs. So every morning, our research coordinator gets the trauma logs. That tells us when somebody came in. The video's all pulled off. We then go to those times, and the video's spliced for length, and then de-identified, because at the top of the camera is just like any security video. It has like the date and time. So that gets blacked out. And then, and we'll talk about why this happened, but the patient's face is blurred, and any identifying like tattoo or anything like that gets blurred. So that's the post-processing that has to happen. And a lot of that would have to happen regardless of how you activate it. But there was a lot more video, quote, on the floor because we were running these all the time. The only time we lost video twice. Once was because President Obama came into town and we had to shut them off. The Secret Service made us, even though he never came to the hospital. And once because a very well-meaning cleaning lady somehow unplugged something, and we didn't realize we had, I'm sorry?
We just lost audio.
We lost audio. But we didn't realize that it happened until like a couple days later. So we actually, we lost a subject, not because of that, but we did lose a subject because of the Obama incident, because we didn't have enough videos for that individual.
For the sound piece, could you not mic the participant themselves because they were also seeing patients?
Well, yes, I'm sure, but we simply didn't have the resources to do that. Like, we didn't have a coordinator 24/7 in the environment. We would have loved to have collected multiple different kinds of data from, the nurses, and we'll sort of talk a little bit about how we saw some culture change that we would have loved to be able to capture, and we just couldn't. But yeah, and in a perfect world, everybody would wear a mic, and we'd be able to isolate it, and it would be really cool. But it did not happen.
Also hesitant to do anything that would call attention to the fact that we were doing what we were doing.
Yeah. I think a couple more mics would have been nice, but we just didn't. And a camera that caught the foot of the bed. I don't know if you noticed, but we had a camera at the side and a camera at the foot pointing ahead, and we would have liked to have had a third view, but that just got expensive for a number of reasons.
I would also say the issue with the sound wasn't that it wasn't sensitive enough to pick the individuals up. It was that there would be enough background noise, and we had curtains between the next resuscitation bay, so you could easily hear the interview going on there if depending on where the sound was coming from. So more cameras wouldn't necessarily fix that problem because you would just pick up more of that background noise.
Mm-hmm. So this slide sort of talks, we went to risk management first. So we started with risk management, and we did that because there was another project that sort of happened within the institution that was related to video recording, and they were heavily involved, so we thought we'd start there. What was lucky for us is that our work was research, not QI. So the research was not discoverable. So they became much more friendly to us when they found out that we were funded. So we had a federal grant, which kind of gave it some weight. It was not QI. There was no way we were going to use this for quality improvement in any way, shape, or form. And we made that very clear that no way, no how, nobody could ever request to look at these videos. And then we had a certificate of confidentiality from the federal government. So I don't know, are you guys familiar with that? So NIH has this thing, and I don't believe you need to actually have NIH funding to apply for it. But it essentially holds that your data are protected from discovery. And anybody can apply for it. And it just helps with the confidentiality piece. And I actually found out about it when I submitted my grant. One of the reviewers said, you should do this. And so I did. But risk management really liked that as well. So just to keep in mind, and actually AHRQ's certificate of confidentiality is stronger even than NIH's. So we were very well protected. The primary challenge was sound, again, and not, it was sort of strange, but the laws haven't caught up, apparently, since like 1970. So wiretapping laws, at least in Washington, were the big driver. And I know that's also an issue in California. I have a friend who video records putting babies on ECMO, and she can video record up the wazoo, but she can't record sound. And so all she has are actions and not any communications. So what we had to do is post signs in those areas so that patients or families could request to move to a different area, and that never happened. But that was part of our concession to that piece of it. If you're being audio recorded, you have to let people know. And I think it kind of goes to some of that, people recording you on their iPhone and things like that. It would have been a violation of wiretapping laws, not video. But ultimately, our driver was that we wanted to keep the video. We didn't want to have to destroy it, which is like within 3 days or something, which is very common at a lot of places that do this sort of work. And the reason is that we wanted to be able to analyze them in a meaningful way, and that takes a lot of time. And so after risk management gave us the thumbs up, we then went to the IRB. And part of the challenge was, who do you consent? So do you consent the patient? Do you consent every team member? If we had to consent every team member, every time there was one team member that didn't want to consent or that we couldn't find, we would have to throw that away. And so we sort of went into them saying that we wouldn't be able to do that. How can we work around that? And so that's where the patient blurring came from and the de-identification. Now, they acknowledged and we acknowledged that they call out the patient's name sometime. Like, we can't stop that. But it was considered de-identified enough that we did not have to consent the patient. And we had to notify the groups of people that would be constituting team members. And they would have the choice. For instance, we had one nurse who didn't want to work in those two areas. That was fine. I mean, 1 out of something like 60, so I was good with that. But we had to let environmental services know, security know, all these groups, and actually our assistant nurse manager helped a lot because we don't interact with those groups. So there isn't a level of trust, which we had with the nurses, which made that part pretty easy. And then it was just, how are you going to keep these things secure? And so we went through a lot of, okay, our video processors would be in closed room with the door closed and no windows, and if you're going to code these videos, obviously you can't take them out of the system, and you can't go and do it at Starbucks, and all these kinds of things. But there were practical things like these have to use really high-powered processors, so the room would get overheated, but then we couldn't open the door. So I mean, there were just like these little things that I never even thought about that we encountered. So after we got the video recording, we then had to really give some thought to baseline performance. And I'm kind of curious about this because how do you, what does that mean? How do you assess their baseline to know that your training had an effect? And so it would have been awesome to be able to say PGY year, but we all know that that's not a good measure. And certainly in training, exam scores are not a good measure. So hence the pre-post design was born. And we said, great, we'll do this. And that's what we did. But then the question became, how many? And if somebody has an answer for that, by all means, let me know. But we had no idea how many events we had to observe before we knew what somebody's performance actually was. 10? Is it 10 and 10? Is it 20 and 20? There's a lot of variability of patients. So how do you figure that out? So when I show you this, you're going to be shocked at the number. But we chose this, and we chose it for very practical reasons. We chose it because it was all we could do. We would have loved to have had 20 on each side, but the fact of the matter is we enrolled 68 learners. That's 6 videos per learner. We needed to code some of them in duplicate. Assuming our inter-rater reliability was good, we could stick with 10%, otherwise we'd have to do more. There were 2 separate measures, patient care and leadership, and each video is 20 to 30 minutes long. So when you think about the coding burden, we were simply stuck with what we could feasibly do. And even that, it says over 400 hours of observation. It's way more, I promise. Because you have to go back and look at other things and be really careful. I don't know if there's anything you want to comment on with that. Okay. So we know that it wasn't perfect, but it was one of the things that we had to live with. One of the studies I'd love to do, now that we have all this video, is kind of answer that question of what is the variability of performance of a single resident across a given measure, and when do you know? When do you saturate? So, because we could put together curves for all these folks and figure out when we actually knew what their final performance was going to be like, if that makes sense. So that's one of the things that would be kind of neat to do with this. And so, Liza, do you want to do measurement?
Yeah, and I'll just use this. Okay. So, yeah, it's a little overwhelming to think that maybe we've done all this work, and if we had captured a couple more video observations, that might have made the difference. But we'll go through some of the measures that we coded these videos for, and 400 hours doesn't even touch it. So process measure, performance measure, and a patient level outcome. So when you put the process and the performance measures together, those are both that T1 translation, and then the patient level outcome is the T2 translation. And although our primary objective was, our primary outcome is the process measure, the team leadership, working with our collaborators and working in the team sciences, we know that we are supposed to do process and performance together to better understand the impact of our training. So we'll start with the process because that was our primary objective, and so team leadership. Just like with the training itself, there's a fair number of measures out there that involve team leadership assessment in healthcare. There's maybe a handful that are actually focused on team leadership, but we got into this dilemma in which looking at the translational model, we wanted to look at the transfer of behaviors we trained to the clinical environment. So we didn't just want to we did want to look at better team leadership. That's what we were looking for, but specifically those behaviors we trained. And so in order to address that, we decided to create our own novel measure, which just added on additional work because we can't just create it and say that it's good. We had to go through the iterative process of EM and team science people from across the country reviewing it and refining it and reviewing sample codes and seeing if it worked. So that's what we ultimately decided to do, and so that we could actually capture what we were trying to train. The performance measure, so that's the clinical care that was delivered, not the patient outcome, but the bedside clinical care. So this was coded in parallel to the performance measure, but by a different set of coders, because you don't want to determine what their team leadership was and then have that impact how you score their performance. This is complicated because trauma care in some ways is really standardized, right? And what we ended up using, we essentially modified an existing ATLS checklist, right? There are ATLS checklists out there. But you either get into something that's quite generic because it has a primary survey and a secondary survey and some things that most patients get, or it gets too specific, and with patient variability, it might not all be indicated. So what is the image indicated in a gunshot wound to the head versus a blunt abdominal trauma? And so what's indicated changes. And so we tried to balance it between being too general and too specific. And we essentially modified an ATLS checklist that included some of these more specific elements of care, and then got another group of coders who were emergency medicine physicians to look at the videos and comment on whether a diagnostic or an intervention was indicated or not. Were those blood products indicated? Was a CT head indicated? Actually, we didn't do CT head, but chest x-ray or whatever it was. So that was actually, we didn't anticipate to do this third level of coding, but we did, and that also 10% in duplicate to determine our reliability. So then when you do that, then your checklist changes depending on the nature of the patient. So this becomes very complicated, and data analysis becomes very complicated. We were not powered to see a difference in this outcome. We don't know, right? Like I said, we don't have our results yet, so I don't know, but this isn't where we're putting our money, but it was important that we looked at it as well. And then lastly, and probably what's interesting people the most, is the patient outcome. And how did we take that to the patient outcome, especially because the patients weren't consented. But we have the trauma registry, right? We're a trauma center. And specifically, we are the only level 1 trauma center for a 5-state region. So what we call the WWAMI region, Washington, Wyoming, Alaska, Montana, and Idaho. I should know it by now. So a lot of patients, and it has a lot of variables in it, and it's really well maintained. And so we have this as a resource, but we had to be able to link the data from that to our without including the patient to the team leader that we trained. And so we did that right. Our team leaders consented, but the patient isn't. And so we have someone who's not part of our research team, who I've never met, who is a data steward for us, who essentially gets this data. So when it comes to us, de-identified, and then is linked to our study ID so that we can link across all of our measures. So that in together, to take you back to all the red questions of how do we handle this, I mean, this is what we came up with. And it's not all perfect. We made a few concessions or just a few guesses and based on how many observations we had to make pre or post and how far we could go out in the post-training assessments. But we were actually pretty happy with this, and we were able to kind of tease out what all of our outcomes looked like. And so here's the final answer. And taking you back just to the model again, that team leadership process measure and that team performance clinical care checklist were that T1 translation. And then our trauma registry is filling in, linking us, doing that T2 process.
And Liza, can I just interrupt? And so, sorry. And so the other piece that we're able to get from the trauma registry are things like injury severity score, so that we can use those as control variables. So I kind of forgot to mention some of the covariates that we're going to include in the model. But that's the other thing that trauma registry provides for us. So that's actually why we did trauma. I mean, because we had that and we didn't have the budget or the means to consent the patient and go into like for cardiac arrest. We don't have that kind of data for cardiac arrest.
And then just briefly, we mentioned there's a lot of things that we might have wanted to capture that we didn't. And what became very interesting in us, so that our participants were randomized within the month, because we understood that this was going to happen over several years, and that maybe their education training or their trauma doc training would change. And here we would have had all of our controls or all of our interventions, and then their education changes, and then our whole study is flawed. And so they were randomized in the month. What we did not anticipate is that our training might be that change that happened through the years. And what we saw that was so fascinating is our learners, as they grew up, as they became senior residents, started training our junior residents who entered the trauma doc role. And I remember getting a text from who's now a chief resident going, "Awesome, just worked a trauma shift with so-and-so, and I taught him how to do the, whatever." I was like, no. No, can you wait 6 more months? And then, and it happened. It happened, and we explained to them, and then our chiefs wanted to take a mini version of our training and do it at their chief rounds with the residents. We're like, thank you for asking us first, and no. You can train them on lots of things, but not that. And then our nurses started learning the language. I talked about priorities earlier. They really liked that. They liked knowing what the resident was thinking and we need the Foley, but we don't need it before we need the head CT. Like, let's get our priorities straight here. And so they started asking for it. And so some of our more senior, they'd be like, "So what's the priority here?" And so, and that would happen whether the trauma doc was a control or an intervention subject. And so we didn't expect, so we can say anecdotally we think this was awesome. Now, we'll see what the results show. And so part of that, we talked as we went along, like it would have been really awesome if we had captured nursing satisfaction. Because what was happening is they were leaving these codes and going, "Man, so-and-so did so well," and they just felt like they were included. They felt like they knew what the plan was, and they were working towards that plan with the resident. We didn't do, there's only so much you can take on, and we knew we wanted to capture that. We also knew that we weren't going to, but it is one of those things we continue to say, that would have been fun. And that's it. I think we want to just kind of, be nice if we could say take-home points like this is how you can go do this, right? Everyone's institution is different. It depends on what problem you're trying to tackle, what subject, team leadership, teamwork versus, central lines, all very different. But what outcome, and this came through when we did our team leadership assessment, what outcome would reflect your intervention? And then that's where like the nursing satisfaction actually, isn't a proximal outcome, but is something that you might capture. But we wanted to make sure we linked directly to it. So we started with that transferred behavior. And then thinking, what else might I be able to impact, and what else do I want to look for? What can you reliably capture? This could be in person. This could be through video recording. It could be through chart abstraction. But depending on what modality you use, what do you think you can get consistently? And if you're getting that thing consistently, the video or the in-person, what can you actually code from it? a very practical level. What can you get through? And that's been a real challenge for us. And then finally, what variability are you willing to live with? And I think that comes, we worked with some people who are so used to simulation lab-based assessments and concrete thinkers. And I was used to that too, where you can directly tie your simulation to what you're looking for. You can force certain behaviors to come out if you want. And we can't do that here. And if you really like that control, I mean, this can make you crazy. But it's fun. I think this is a lot of fun. But you just have to decide whether you're comfortable with that, because there's a lot more uncertainty and a lot more variability here. Did you want to add to that at all?
No, I think we can just kind of put up that next slide and then go to questions, just so you guys have time. I mean, these are sort of the truths that we came up with from what we learned, if we had to summarize them into 3 statements. But
nothing life-altering.
Nothing life-altering. You probably already knew this, but if there are any questions, we'd be happy to take questions. Yeah.
I'm supposed to make you.
Oh, yes, that's right.
Kind of a meta question, because we have a lot of young SIM investigators, is this K award, R award, the mentoring relationship, that kind of, like, that brings something like this about?
Yeah, so this is an R18. This is the second R18. So it's translational, right? So we didn't just wake up one morning, and I know you all know this, and just decide to do this. Liza has been a colleague for me. She is, and really a partner in research, but this is an R18 through AHRQ. And we have the next grant to do this multi-centered, but that's through the DoD. And so that's how we sort of did it.
And before you got to this R level, did both of you do K awards, or did you had formal research training in addition to your simulation training?
No, so I was really lucky. I have research training in basic science, so completely useless. And then the R18 started to come out. I think it was the second round that they were funding back in, I think the announcement came out in 2011. Mm-hmm. And it was sort of perfect. And I thought, if I'm going to give it a try, because this should be the way. And I was partnering with PhDs in psychology, and so they provided sort of that knowledge for me, which I think I don't pretend that I have a PhD. Let me be clear, but I feel like at this point I have a fair amount of knowledge of team science. But back then I really needed them. And then Liza started on our project straight out of residency.
Yeah, so my answer is no. That's easy. And I think it just worked out, and I think it can, but I'm not the PI, right? So I was brought onto projects 7 years ago, and I've been doing it on the job training since then. And yeah, it's just worked out.
Yeah, the hardest part is probably that I didn't have training in project management. And I think that was the biggest, and continues to be the toughest part, is actually managing the project. And this works because we have a research coordinator extraordinaire. We really do. And that's why this works.
Yeah, I would second that for any project I've succeeded with. It's all about project management and having the dedicated research coordinator resource. Others with questions?
I'm not a SIM person, but I'm an educator and hospital administrator. So I love your persistence and creativity and hard work. I thought that was awesome. But I think you're running into the problems that we find all the time when we take educational interventions and try to apply them and see how they're coming out both in behavior with physicians and in outcomes. And it's such a challenge, like you said, not just the technical challenges of doing the video, but then interpreting it. So I'm going to ask you a question. If you had to do this, start over, knowing what you know now, what would you change?
That's a good question. Do you want to go first, or do you want me to do?
I mean, I think for me, I would have spent a little bit, if the funding, let me put it this way, if the funding cycle were to agree with it, I would have spent a little bit more time on measurement up front. I would have tried to understand the variability and how to handle that in a more timely manner so that we weren't sort of rushing to do it. I think, as Liza said, I would love to have a full day of training. We just couldn't. So there were things that I don't think would have changed, but I think for me, a little bit more understanding of the management piece up front, or not the management, I'm sorry, the measurement piece up front would have been what I would target.
Yeah, I think we potentially, and this is on a practical level, I think that if we had known the coding burden in advance, we might have been able to plan for that better as far as how resources were spent and where they went, and creating a more realistic timeline and the video processing goes into that too, instead of having not any of that and suddenly, boom, gotten hit with hundreds and hundreds and hundreds of hours of coding that had to be done. That just doesn't feel good.
Yeah,
so I think that could have been managed better, but we just didn't know this was. And we have coded videos before for projects. Like, we're not new to that. And we use a software program to help. It just holds the results. It doesn't do any of the analysis. But this was just different, and so now we know going forward maybe how to divide that labor. And then I think the other thing I would change is we had talked about this early on, separate from nursing satisfaction, which I know we didn't have the resources to capture. We didn't even capture the residents' perception of the training because we're trying to move past that and perception. But in the end, we know there was something there. We know this mattered. I have senior residents being like, your training has made me more confident, and lasting years later. And so I don't know what our results will be, but to not have anything to have shown what seems to have been really impactful feels a little bit frustrating. I mean, I don't know that will be the case. We might actually show a change. So I think that would be the other thing, because that would have been easy to do.
So the other thing you might think of is down the line, looking at your trauma quality measures over time to see if it had any effect on those outcomes. And that's more a population sense of outcome rather than an individual behavior outcome. And hospitals a lot of them are already measuring that in ways that you probably just need to find out about. Mm-hmm. So that would be more data for you.
Yeah. Yep.
Yes.
I'm just curious if you considered other things besides video. I know that's really where you went with this whole project, and that may be very off topic, but I know that in my institution, video is just not on the table at all, because I've explored it. So I'm just curious what else you looked at.
Yeah, and I actually had to write it into the grant. So this wasn't funded on the first go-around. It was funded on a resub, which, surprise, surprise. But since we didn't have the protocol in place for this project, we had to propose an alternative, and the alternative was to have direct observation. We just knew that what we were going to be able to capture was going to be so diluted when we did that. But that was our fallback, and we had to actually write it into the grant. Now, when we applied for our DOD grant, because we had this all set up, we didn't have to address that piece anymore. And one thing I'll say, I think to the other gentleman's question about what we would have done differently, to give you an example, we were told that it would take 15 minutes to process each video, and it takes about an hour and a half. And so, not to code, just to process. And so
that was after it was streamlined down from 4 hours.
Yes. So, lessons learned, all that kind of stuff. But that's.
I think that is one advantage of direct observation, is you get your checklist or whatever it is that you're using, and the processing time is quite different than the video. But obviously, then you lose all these things that you didn't know you needed, and you can't go back and look at them.
Right. For us, we were not that we told ARC this, but we now have this database. We actually have 600 videos. And so we feel like we can ask a lot of different questions, like the learner-related question that was, kind of came up as a part of this. So I think we're eating into others' time. So we'll just say thank you, and please feel free to contact us. I have to literally run out the door to the airport, but Liza might be here for a few. Or if you want to just send us an email if you have any specific questions, we're happy to answer them. So thank you so much.